Welcome to Chapter 7, the Vascular System and Hemodynamics. This is part of course, our class, HTL 302, the Pathological Basis of Clinical Medicine. This chapter sets the stage for a lot of what we'll talk about moving forward because the vascular system is essentially the delivery and waste removal service for every tissue in the body. If blood flow is disrupted, tissues suffer, and that suffering shows up microscopically. When we talk about hemodynamics, we're talking about how blood moves, how fast it flows, how much pressure it's under, and how easily it can move through vessels of different sizes. Think of the vascular system like a city's road system. Arteries are highways, arterioles are major streets, capillaries are those tiny side roads, and veins are the return routes back to the heart. Traffic jams, detours, and road damage all have consequences. And in pathology, those consequences leave structural clues in the tissue. For histotechnologists, this chapter is critical because vascular changes affect tissue viability, inflammatory patterns, edema, thrombosis, and how well a specimen actually presents disease. If the blood can't get there or can't get out, the slide will tell that story. Before we dive in, let's take a quick look at what you should be able to do by the end of this chapter. You'll review the basic structure and function of the vascular system, not just memorizing layers, but understanding why those layers exist. You'll identify common and serious vascular diseases, including those that affect arteries, veins, and capillaries. We'll spend time on edema because fluid balance is one of the most important and most misunderstood vascular concepts. Edema isn't just swelling. It's a clue that something has gone wrong with pressure, permeability, or protein balance. You'll also learn to distinguish arteriosclerosis from atherosclerosis and arteriosclerosis. Yes, they sound similar. No, they are not the same thing. Understand how atherosclerotic plaques develop and which vessels are not commonly involved. Define hypertension and differentiate essentially from secondary causes. Compare thrombophlebitis and varicose veins, and understand shock, including how and why it becomes life-threatening. From a histology standpoint, the goal is not memorization, it's pattern recognition. If you can connect vascular dysfunction to tissue appearance, you're exactly where you need to be. Let's start with a quick review of structure and function, because pathology only makes sense when you know what normal looks like. The vascular system actually includes two systems, the blood vascular system and the lymphatic vascular system. Today, we're focused primarily on the blood vascular system, which includes arteries, capillaries, and veins, all working together to move blood to and from the heart. Capillaries and venules are where the real magic happens. This is where oxygen leaves the blood, nutrients are delivered, and metabolic waste is picked up. Why here? Because blood flow is slowest and vessel walls are thinnest. From a histology perspective, that thinness matters. It's why capillaries are so delicate on slides and why fixation artifact can be misleading if you're not careful. Now, arteries and veins share a common basic structure with three layers. First, you have the tunica intima. This is the inner layer made of endothelial cells sitting on a basement membrane. In small vessels, especially, this layer is critical for controlling exchange between blood and tissue. Endothelial dysfunction is a huge player in vascular disease, and you'll see that theme again when we talk about atherosclerosis. Second, the tunica media. This layer contains smooth muscle and elastic tissue, and it controls vessel diameter. Vasoconstriction narrows the lumen. Vasodilation widens it. Think of this like a camera lens adjusting focus. Small changes in diameter can dramatically affect flow and pressure. This is also why chronic hypertension causes structural remodeling. Vessels adapt, but not always in a good way. Third, the tunica adventitia. This outer layer provides structural support and anchors the vessel to surrounding tissue. It's not glamorous, but without it, vessels would be unstable and prone to damage. And finally, the lumen, the open space where blood actually flows. When we talk about thrombosis, narrowing, or obstruction, this is the space we're talking about. From a histotechnologist's perspective, all of this matters. Orientation, section thickness, and fixation quality can dramatically change how these layers appear, and whether pathology is obvious or subtle. On this slide, we're pulling together structure, function, and flow across the vascular system. Everything here is foundational, and you'll keep coming back to these concepts when we start talking about disease. Let's start with the artery wall diagram on the left. You can see the three classic layers: the tunica intima on the inside, lined by the endothelial cells sitting on a basement membrane; tunica media, which is thick in arteries and packed with smooth muscle and elastic fibers; the tunica externa, or the tunica adventitia. It's made of connective tissue that provides support and anchoring. From a histology standpoint, arteries are easy to recognize because of that thick tunica media and relatively round lumen, at least in well-fixed tissue. If you see a thick wall and a smaller, more circular lumen, you should be thinking artery right away. Now look at the vasoconstriction and the vasodilation images at the top right. This is the tunica media doing its job. When smooth muscle contracts, the vessel narrows. That's vasoconstriction. When it relaxes, the vessel widens. Vasodilation. A helpful analogy here is a camera aperture. A small change in diameter dramatically changes how much light, or in this case blood, can pass through. That's why vasoconstriction and vasodilation have such powerful effects on blood pressure and tissue perfusion. As a histology tie-in, if a vessel has been chronically constricted, you may see medial hypertrophy over time. That's not just physiology, it becomes pathology. Now let's move to the capillary network diagram on the right. This is where exchange happens. Capillaries connect arterioles to venules, and their walls are incredibly thin, usually just a single layer of endothelial cells. That thinness allows oxygen, nutrients, and wastes to move between blood and tissue. This is also why capillaries are fragile on slides. Overfixation, poor processing, or thick sections can make capillaries almost disappear, or worse, make them look collapsed when they're not. Finally, look at the types of blood vessels diagram at the bottom. Arteries, they carry blood away from the heart. They have thick walls and a smaller lumen, designed to handle high pressure. You have capillaries, which is the site of exchange. They are thin walls with tiny lumens. Slow blood flow, which is intentional. And then we have veins. They carry blood back to the heart. They have thinner walls and a larger lumen, often look irregular or collapsed on slides. And a fun histology reality check here are that veins are the drama queens of histology. They collapse, fold, and distort easily. And students often mistake them for something weird when they're just being veins. The big takeaway from this slide is this: structure always reflects function. And when function is disrupted by pressure, blockage, inflammation, or injury, that disruption leaves morphologic evidence in the tissue. As technologists, your job is to preserve those clues so the pathologist can read the story correctly. This slide introduces one of the most important concepts in vascular pathology. Arterioles are the main regulators of blood pressure and tissue perfusion. Even though we often think about blood pressure as something the heart controls, the vessels, especially the arterioles, are doing most of the day-to-day fine-tuning. Arterioles act like dimmer switches, not on-off switches. By narrowing or widening just a little, they can dramatically change how much blood reaches a tissue. That brings us to the equation on the slide. The blood pressure equals our cardiac output times systemic vascular resistance, or simply BP equals CO times SVR. Cardiac output is how much blood the heart pumps. Systemic vascular resistance is how hard it is for blood to move through the vessels, and that resistance depends largely on arterial diameter. Here's the key idea. Small changes in arterial caliber produce big changes in blood pressure. From a histology perspective, this is why arterioles are such important targets in disease. Chronic vasoconstriction doesn't just raise blood pressure, it leads to structural remodeling of the vessel wall over time. Now let's talk about the two numbers we see in a blood pressure reading. Systolic pressure is the maximum pressure in the arteries when the heart contracts. In a healthy adult, this is around 120 mmHgs. This pressure reflects how forcefully blood is being pushed into the arterial system. Diastolic pressure is the lowest pressure between heartbeats, usually around 80 mmHg. This tells us how much resistance remains in the system when the heart is relaxed, again pointing us back to arterial tone. Why does this matter for histotechnology? Because long-standing elevated pressure, especially diastolic pressure, causes arterial wall thickening, narrowed lumens, and reduced tissue perfusion. On slides, this can look like increased smooth muscle in the tunica media, a reduced lumen diameter, and then downstream ischemic changes in the tissue. A quick analogy here, if you constantly run water through a garden hose at high pressure, the hose stiffens and wears out over time. Blood vessels behave the same way, except the consequences are cellular injury, not a leaky lawn. So when you see small, thick-walled vessels with tiny lumens on a slide, you should be thinking about chronic pressure changes, not just, hey, that looks weird. This concept sets us up perfectly for the next section when we'll talk about edema, congestion, and vascular injury, all consequences of altered hemodynamics. Now that we've talked about the arterial side of circulation, let's shift gears to the venous side, which operates under very different conditions and creates a very different set of pathologic patterns. First, notice the number. The mean venous pressure is about 30 mmHg, which is much lower than arterial pressure. Veins are not designed to handle high pressure, and that's reflected directly in their structure. Veins have thinner muscular walls than arteries, they have larger lumens, and there is less muscle in the tunica media. From a histology standpoint, this is why veins often look collapsed, irregular, or folded on slides. They're not bad sections, they're just being veins. The primary function of veins is simple but critical. Return blood to the heart from the capillary beds. But here's the important question. If venous pressure is low, what actually moves the blood back to the heart? The answer is leftover pressure plus help from the body. Venous return relies on residual pressure from the arterial side, skeletal muscle contraction, so think walking, respiratory movements, breathing literally pulls blood towards the heart. This is why people who are immobile for long periods, like bed rest, long flights, long surgeries, are at higher risk for venous problems. Veins also contain valves, especially in the lower extremities. These valves prevent backflow and help blood move in a one-way direction towards the heart. A fun but useful analogy here, think of veins like a series of one-way doors in a hallway. As long as the doors work and people keep moving, traffic flows. When the doors fail or movement stops, things back up. And that brings us to the key pathology term at the bottom of this slide, congestion. If blood flow in veins is obstructed by blood clots, external compression, or heart failure, blood backs up, veins descend, and venous pressure increases. That backup is what we call congestion. Histology tie-in here, congested tissue often shows dilated, blood-filled veins and capillaries, darker bluish-red coloration grossly, and then downstream effects like edema or hypoxia. And this is why venous pathology is so important. It doesn't just affect vessels, it affects entire tissues and organs. So when you see dilated vessels packed with red blood cells on a slide, especially on the venous side, you should be thinking about impaired outflow, not increased inflow. Okay. Now we arrive at the capillaries, which are arguably the most important vessels in the entire vascular system, even though they're the smallest and easiest to overlook. Capillaries are the small vessels that sit between arteries and veins, forming a massive network that connects arterioles to venules. This is where all meaningful exchange happens. Structurally, capillaries are extremely simple. They consist essentially of only a tunica intima, just endothelial cells and a basement membrane. There's no tunica media, no smooth muscle, no adventitia, and that simplicity is intentional. From a histology perspective, this means capillaries are very thin, very delicate, easy to collapse or distort during processing. If you've ever wondered why capillaries sometimes look like faint outlines on tiny slits on slides, this is why. One of the most surprising facts on this slide is that in aggregate, capillaries contain the largest volume of blood in the vascular system at any given time. Not because any one capillary is large, but because there are so many of them. Think of capillaries like side streets in a city. Individually, they're small and unremarkable. Collectively, they carry most of the traffic. Capillaries are also highly adaptive. They open when tissues need more blood, like during exercise or inflammation, and they collapse when demand is low. This dynamic behavior helps the body distribute blood where it's needed most. The histology tie-in is collapsed capillaries on a slide don't always mean pathology. Sometimes they reflect physiologic regulation, not disease, so context matters. Another key concept here is capillary proliferation. Capillaries can grow new branches to help repair injured tissue, a process called angiogenesis. You'll see this in wound healing, granulation tissue, chronic inflammation, and tumor growth. A fun but slightly unsettling fact, tumors are excellent at hijacking angiogenesis. If they can't recruit capillaries, they can't grow beyond a very small size. Finally, remember this. Capillaries themselves don't control blood flow. They have no smooth muscle. Instead, flow through capillaries is controlled by the arterioles and the venules on either side. So when something goes wrong with capillary exchange, edema, hypoxia, inflammation, the problem often starts upstream or downstream, not in the capillary itself. For histotechnologists, capillaries tell a subtle story. They don't shout, they whisper. And learning to recognize their patterns is a huge step towards thinking like a diagnostician. Slide explains why fluid moves and why it sometimes moves to the wrong place. Capillaries regulate the exchange of fluid, electrolytes, and nutrients between the blood and the extracellular space. That exchange is not random. It's governed by three major factors, and if any of them is disrupted, fluid balance falls apart. Let's walk through them one at a time. So the first one is hydrostatic pressure. Hydrostatic pressure is the force exerted by fluid pushing outward against the vessel wall. In the vascular system, hydrostatic pressure is transmitted from the arterial side, influenced by venous pressure, and ultimately determined by blood pressure. You can think of hydrostatic pressure like water pressure in a hose. The higher the pressure, the harder fluid is pushed out of the vessel. When hydrostatic pressure is too high, such as in heart failure, venous obstruction, or prolonged standing, the fluid is forced out of the capillaries and into the tissue. The histology tie-in here is that increased hydrostatic pressure often leads to interstitial edema, with widened spaces between cells and pale washed out tissue appearance. The second one is osmotic or oncotic pressure. Osmotic pressure is the pulling force that draws water towards areas with higher solute concentration. In blood, this is driven largely by proteins, especially albumin. Albumin stays inside vessels and acts like a sponge, holding water in the circulation. A useful analogy here, hydrostatic pressure pushes fluid out, osmotic pressure pulls fluid in. Think push versus pull. When osmotic pressure drops, such as with liver disease, which is low albumin production, or kidney disease, which is protein loss, or even malnutrition, then fluid is no longer pulled back into the vessel and it accumulates in the tissues. Histology tie-in. Low oncotic pressure produces generalized edema, often affecting multiple organs rather than just a single region. And then number 3 is endothelial integrity. The third factor is the integrity of the endothelial cells lining capillaries. Healthy endothelium acts as a selective barrier, allowing small molecules through by keeping proteins inside the vessel. When endothelial cells are damaged by inflammation, infection, toxins, or trauma, the capillaries become leaky, allowing both fluid and protein to escape. This is why inflammatory edema looks different from pressure-related edema. Histology tie-in here is endothelial injury often correlates with inflammatory cell infiltrates, protein-rich edema, and more dramatic tissue disruption. Well, what happens when these systems fail? Well, any alteration in hydrostatic pressure, osmotic pressure, or endothelial integrity can result in edema, which is accumulation of fluid in the tissues, or effusions, which is accumulation of fluid in body cavities like our pleura, our peritoneal, or the pericardium. From a histotechnology standpoint, recognizing edema means looking for those widened interstitial spaces, separation of tissue elements, and diluted staining patterns. But just as important is understanding why the edema is there. Is it pressure, protein loss, inflammation? Because the tissue tells you that edema exists, but pathophysiology tells you the cause. This diagram puts everything from the last two slides together and shows you what is happening along the length of a single capillary. We're going to walk from left to right, arterial end to venous end, because fluid movement changes as blood moves through the capillary. The arterial end capillary hydrostatic pressure is high, about 35 millimeters of mercury. At the same time, blood colloidal or oncotic osmotic pressure, which is driven mainly by albumin, is about 25 millimeters of mercury, or mmHg. So what wins? Hydrostatic pressure, of course, because the pushing force is greater than the pulling force. Fluid is pushed out of the capillary and into the surrounding tissue. So 35 is greater than 25, therefore the fluid is pushed out of the capillary and into the surrounding tissue. That outward movement is called filtration, and this is normal. It is expected. This is how tissues receive oxygen, nutrients, and electrolytes. A histology tie-in here is, at this point, fluid leaving the capillary is low in protein and not inherently pathologic. So as the blood moves along the capillary, the hydrostatic pressure begins to drop, now around 25 millimeters of mercury. Osmotic pressure stays relatively constant at 25 mmHg. So now the forces are equal. Push equals pull. The result, no net movement of fluid. This is the equilibrium point, and it's why most fluid exchange happens towards the arterial side rather than the middle of the capillary. By the time the blood reaches the venous end, capillary hydrostatic pressure has dropped further to about 18 millimeters of mercury. Osmotic pressure is still about 25 millimeters of mercury. Now the pulling force is stronger than the pushing force. So fluid moves back into the capillary. That inward movement is called reabsorption. And this is how fluid that exited earlier is returned to the circulation. An analogy here that usually clicks is, think of this like grocery shopping. You leave your house with bags, so fluid leaves the capillary, you do your shopping, and then you bring most of the bags back home. If something interferes with that return trip, the bags pile up outside. Why does this matter clinically? Well, edema occurs when too much fluid is pushed out, too little fluid is pulled back in, or fluid escapes through damaged endothelium. If reabsorption fails due to increased venous pressure, decreased albumin, or endothelial injury, fluid remains in the tissue. So histology tie-in is that persistent edema produces widened interstitial spaces, a separation of cells, and pale or washed out tissue architecture. And importantly, the problem is often not the capillary itself. It's what's happening upstream or downstream. So key takeaway is that you do not need to memorize every number on this slide, what you do need to remember is this pattern. The arterial end is where filtration happens. The mid-capillary is balanced, right? Push equals pull. And the venous end is where the reabsorption happens, okay? If you understand that sequence, you can reason your way through edema, congestion, effusions, heart failure, liver disease, and even kidney disease. And that's exactly what this course is training you to do, okay? So up to this point, we've talked about fluid leaving capillaries and most of it being reabsorbed on the venous end. But here's the key question. What happens to the fluid that doesn't get reabsorbed? Well, that's where the lymphatic vascular system comes in. The lymphatic system is unique because it doesn't start like the blood vascular system. There's no central pump and no continuous loop. Instead, lymphatic vessels begin as blind-ended, thin-walled channels embedded directly in tissue. So think of them like emergency floor drains. They're there to catch excess fluid that doesn't make it back into the bloodstream. These tiny lymphatic channels collect fluid from local tissues and carry it towards lymph nodes, where the fluid is filtered and immune surveillance takes place. From there, lymph nodes drain into larger lymphatic channels, which eventually converge into the thoracic duct. The thoracic duct empties lymph back into the venous system, effectively returning that excess tissue fluid to the systemic circulation. So fluid is not extra fluid, it's recycled fluid. Lymph itself is composed of water, proteins, and white blood cells. That protein component is especially important. When proteins leak out of capillaries, they cannot be reabsorbed directly into blood vessels. They must be returned via the lymphatic system. This is why lymphatics are so critical in preventing edema. From a functional standpoint, lymphatic vessels return excess tissue fluid to the venous system. They allow lymphocytes to re-enter circulation, and they help maintain normal fluid balance. Histology tie-in here is that lymphatic vessels are often difficult to see on routine H&E because they have very thin walls, they lack red blood cells, and their lumens may appear empty or collapsed. If you see a vessel with a thin wall and no red blood cells, don't automatically assume it's an artifact. It may be lymphatic. Clinically, when lymphatic drainage is impaired due to surgical removal of lymph nodes or radiation therapy or even tumors or infection or inflammation, the fluid and proteins accumulate in tissues, resulting in lymphedema. And unlike other forms of edema, lymphedema tends to be firm, persistent, and progressive. So key takeaway, the lymphatic system is the safety net for capillary fluid exchange. When it works, small imbalances don't matter. When it fails, edema becomes chronic and difficult to reverse. So this slide kind of completes the picture of fluid movement. The blood vessels push and pull, capillaries exchange, and then lymphatics clean up what's left behind. So this slide shows what happens when the lymphatic system, our fluid safety net, fails. Lymphedema occurs when lymphatic channels are obstructed, preventing lymph from draining properly back into the venous system. When that drainage stops, fluid and proteins accumulate in tissues, and the swelling becomes persistent and progressive. Unlike other types of edema, this is not just extra water. This is protein-rich fluid, which is why lymphedema behaves differently. There are several major causes of lymphatic obstruction. First, external pressure or destruction of lymphatic channels. This can happen due to tumors compressing lymphatic vessels or scarring from prior injury or surgery, or even inflammatory destruction. Excess lipid accumulation in adipose tissue, particularly in obesity, also can contribute. Second, surgical or radiation damage. This is one of the most common causes we see in clinical practice. Removal or irradiation of lymph nodes, such as in breast cancer or pelvic cancer treatment, can permanently disrupt lymphatic drainage. This is why lymphedema is a known long-term complication after certain cancer treatments. Third, a more global cause would be parasitic infection. A tropical helminth causes filariasis, which physically blocks lymphatic channels. While this is less common in the US, it's an important cause worldwide and a classic board-style example. Now let's talk about what this looks like. When lymphatic obstruction is prolonged, affected tissues undergo marked enlargement. Early on, the swelling may feel soft. Over time, however, the tissue becomes firm and doughy due to chronic protein accumulation, fibroblast activation, and connective tissue deposition. When this enlargement becomes extreme, it's referred to as elephantitis. A histology tie-in here is in chronic lymphedema, you may see dilated lymphatic spaces, increased interstitial protein, fibrosis, and thickened skin and subcutaneous tissue. This is not reversible edema. Diuretics don't fix this. Elevation alone doesn't fix this. Once fibrosis sets in, the structural changes are permanent. So a key distinction for your mental framework is this. Edema equals imbalance of push-pull forces. Lymphedema is failure of drainage. And that distinction matters clinically, diagnostically, and histologically. So when you see long-standing localized swelling, especially following surgery or radiation, think lymphatic obstruction, not just fluid overload. So capillaries leak, the veins reabsorb, and the lymphatics clean up the rest. When the cleanup system fails, the consequences are dramatic. This slide introduces the final major mechanism of edema, and unlike the earlier ones, this mechanism is less about capillaries themselves and more about total fluid volume in the body. Sodium retention relates directly to the actual volume of fluid inside the vascular system. When total blood volume increases, hydrostatic pressure increases, and once again, fluid is pushed out into tissues and body cavities. The key organ here is the kidney. The kidneys are the primary regulators of blood volume, not the heart and not the blood vessels. They decide how much sodium and therefore how much water stays in the body. This regulation is controlled largely through the renin-angiotensin-aldosterone system, or RAAS. Receptors in the kidney, heart, and brain monitor blood pressure, blood volume, and perfusion. When these receptors sense low volume or low pressure, they activate RAS. RAS ultimately increases sodium reabsorption in the renal tubules. And here's the key rule to remember, and this one shows up everywhere. Water follows sodium. If sodium is retained, water is retained right along with it. So when RAS is overactivated, or when sodium intake is excessive, blood volume increases. That increased volume raises hydrostatic pressure in the capillaries, which pushes fluid out into the interstitial spaces, edema, into the body cavities, effusions. This is why sodium retention doesn't cause a localized problem, it causes systemic edema. So clinical examples would include heart failure, chronic kidney disease, liver disease, excessive salt intake combined with impaired renal function. The histology tie-in here would be in sodium retention-driven edema. The tissue changes look similar to pressure-related edema. So we'd see widened interstitial spaces, dilution of normal tissue architecture, and again, that pale or washed out appearance. But the root cause isn't the capillary, it's the kidney. This is why diuretics work in some forms of edema, but not others. If the problem is volume overload, reducing sodium and water makes sense. If the problem is lymphatic obstruction or endothelial damage, diuretics won't work. So big takeaway, at this point, you've seen all major mechanisms of edema. So increased hydrostatic pressure, decreased oncotic pressure, increased vascular permeability, lymphatic obstruction, and sodium and water retention. Different diseases use different combinations of these mechanisms, but the tissue response follows predictable patterns. As histotechnologists, your job isn't just to recognize edema, it's to understand why it's there, because that context matters for diagnosis and interpretation. Sinusoids are a specialized type of capillary, and the key thing to remember right away is this. They are not just big capillaries. They are structurally and functionally different, and that is by design. Sinusoids are dilated capillaries that remain more continuously open to blood flow than ordinary capillaries. Their walls are thin, irregular, and much more permissive. If regular capillaries are controlled doorways, sinusoids are more like open archways. This structure allows sinusoids to support specialized functions that standard capillaries simply can't handle. So let's talk about where we find them and why. Liver and spleen. So in the liver and spleen, sinusoids are involved in filtration of particulate matter. In the liver, sinusoidal endothelium is discontinuous and fenestrated, and this allows plasma proteins, lipoproteins, metabolites to move freely between blood and hepatocytes. Histology tie-in here are that liver sinusoids look wide, irregular, and often packed with red blood cells. You also see Kupffer cells sitting along the sinusoidal walls. They did give away you're in hepatic tissue. In the spleen, sinusoids allow for filtering damaged or aged red blood cells and immune surveillance. Again, this requires loose structural control, not tight regulation. And then endocrine organs. In endocrine organs like the adrenal glands and pituitary, sinusoids facilitate rapid hormone exchange. Hormones need to enter the bloodstream quickly, circulate efficiently, and reach distant target organs. The sinusoids allow hormones to pass easily from endocrine cells into circulation without resistance. Histology tie-in here, endocrine tissues often show cords or clusters of cells separated by wide sinusoidal spaces. That pattern is intentional and functional. And then renal glomeruli. The renal glomerulus is another specialized sinusoidal system, but here the goal is filtration of waste products. Glomerular capillaries are designed to allow water and small solutes through retained cells and most proteins. This is why damage to glomerular sinusoids leads to proteinuria, hematuria. A histology tie-in here would be that glomeruli look dense and crowded because they're packed with capillary loops. But those loops are highly specialized sinusoids, not ordinary capillaries. So big picture takeaway, sinusoids exist where the body needs high volume exchange, low resistance, and specialized filtering or secretion. They trade tight control for efficiency, and clinically that trade-off matters because sinusoids are so open they are vulnerable to congestion, sensitive to pressure changes, and easily affected by systemic disease. So when you see dilated, irregular vascular spaces on a side, especially in liver, spleen, endocrine tissue, or kidney, you should be thinking sinusoidal structure and function, not pathology first. This slide is doing exactly what good pathology does. It takes a complex process and organizes it by mechanism, not by memorization. Think of this table as your decision-making framework for edema. When you see fluid accumulation in tissue, the first question is not what disease is this, it's which mechanism is driving the fluid shift. Let's walk through each row. So increased hydrostatic pressure. This is one of the most common causes of edema. Anything that raises pressure on the venous side of circulation will push fluid out of capillaries and into tissues. Classic causes include congestive heart failure, where the blood backs up because the heart can't pump efficiently, or portal hypertension, which is increased pressure in the portal venous system. Venous obstruction, which is thrombosis or external compression. Inactivity, which is loss of skeletal muscle pumping, or hypothermia, which is vasodilation increases capillary pressure. Histology tie-in, this typically produces transudative edema, so low protein, pale, expanded interstitial spaces. Next, we have reduced osmotic pressure. This mechanism is all about albumin. If albumin levels drop, blood loses its ability to pull fluid back into capillaries. So common causes include liver failure, where we'd see decreased albumin production, renal disease, where excess protein lost in the urine. We'd have malnutrition, which is inadequate protein intake, and then intestinal disease, which we would see poor protein absorption. This leads to generalized edema, often affecting multiple organs. Tissue histology tie-in for this one would be tissues look swollen and diluted, but without the inflammatory changes you'd see in infection. Okay. Next up, we have inflammation. Sorry about that. This mechanism is about endothelial permeability, not pressure or protein levels. So during acute inflammation, endothelial cells loosen their junctions, allowing fluid, proteins, and inflammatory cells to escape into tissues. This is why inflammatory edema is localized, protein-rich, and often accompanied by redness, heat, and pain. The histology tie-in for this one is you'll see inflammatory infiltrates along with edema. So context matters here. Next up is lymphatic obstruction. Here, the issue isn't too much fluid leaving capillaries, it's failure of drainage. So causes include tumors compressing lymphatic channels, post-surgical removal of lymph nodes, or irradiation leading to scarring. These all result in lymphedema, which is firm, persistent, and progressive. The histology tie-in here would be chronic lymphatic obstruction leads to fibrosis and thickened tissues, not just fluid accumulation. And lastly, we have sodium retention. This final mechanism is about total body fluid volume. When sodium is retained, water follows sodium. Blood volume increases, hydrostatic pressure rises. Fluid is pushed into tissues and cavities, right? Causes include excessive salt intake beyond renal excretion capacity. So RAS overactivation, especially in the heart, kidney, or liver disease. Histology tie-in here is this looks similar to hydrostatic pressure edema, but the cause is renal and systemic, not local. Every case of edema can be explained by one or more of these mechanisms. Diseases don't read textbooks. They often use multiple rows of this table at the same time. Your job as histotechnologists and future diagnosticians is to recognize edema, understand the mechanism, interpret tissue changes in context. This table is not just a summary, it's a thinking tool. If you can reason your way through it, you're doing pathology correctly. To this point, we've talked a lot about mechanisms, so pressures, proteins, lymphatics, and sodium. This slide answers the next critical question. How does all of that show up in a real patient? Pathology doesn't live in a vacuum. It shows up on physical exam, imaging, and basic tests. So the physical exam, the first clues to edema often come from simply looking and touching. Clinicians will observe for edema, especially pitting edema, in dependent areas like the ankles and the lower legs. When pressure leaves an indentation, it tells you fluid is in the interstitial space. They assess the abdomen, so tapping the abdomen to look for a fluid wave helps identify ascites. These findings point towards systemic causes like heart failure, liver disease, or sodium retention. Histology tie-in. This is the clinical reflection of expanded interstitial spaces you'd expect to see microscopically. And then we have a fundoscopic exam. This is really important point conceptually. The retina and optic disc are the only places in the body where small vessels can be directly visualized. Using an ophthalmoscope, clinicians can see swelling of the optic disc called papilledema. Papilledema often reflects increased intracranial pressure, severe hypertension, or vascular dysregulation. This makes the eye a window into the vascular system. So histology tie-in here, changes here mirror what's happening in small vessels elsewhere. You just can't see those directly. Blood pressure. Blood pressure is not just a vital sign, it's a mechanistic clue. Abnormal blood pressure may indicate increased hydrostatic pressure, overactivation of RAS, and vascular resistance changes. And chronically elevated pressure contributes directly to edema, vessel damage, and end organ pathology. And this connects directly back to your hydrostatic pressure mechanism slide. Angiography allows clinicians to visualize blood vessels in real time. It's used to evaluate vessel caliber, identify narrowing, obstruction, or abnormal dilation. This is especially useful in vascular disease, hypertension-related changes, ischemic conditions. Histology tie-in here, what you see grossly or radiographically often correlates with endothelial damage, wall thickening, or lumen narrowing at the microscopic level. Big picture takeaway here is that this slide bridges the gap between mechanism, what's going wrong, signs and symptoms, what we observe, tests, how we confirm it. As histotechnologists, you may not be performing these exams, but understanding them helps interpret tissue changes, understand clinical context, and appreciate why certain specimens are submitted. Pathology doesn't start at the microscope, it starts at the bedside. Now we're shifting gears slightly away from acquired mechanisms like pressure and inflammation and towards development abnormalities of vascular structures. These are not caused by lifestyle, hypertension, or infection. They arise from abnormal vessel development, usually early in life. Hemangiomas are very common, and you will absolutely see these clinically. They are benign vascular tumors, most often found in the skin, especially in infants, and they are composed of capillary-sized blood vessels filled with blood. Clinically, they appear as small red to purple lesions, often described as strawberry marks. A key reassurance point is that they rarely become malignant. The classic example is a port wine stain, also called nevus flammeus, which is shown here. Most importantly, most hemangiomas resolve on their own. Because of that, surgery is usually not recommended, especially in infants. As a histology tie-in, if you see sorry about that. If you see one under the microscope, you'd expect tightly packed, thin-walled capillaries, endothelial line spaces filled with red blood cells. Next up, we have lymphangioma. Lymphangiomas are less common, but conceptually important. Instead of blood vessels, these involved dilated lymphatic channels, often forming soft cystic masses. A clinical example is a cystic hygroma. A lymphangioma typically found in the neck of an infant. Clinically, these can appear quite large and dramatic. Many regress with age, similar to hemangiomas, though not all resolve completely. Histology tie-in, microscopically, these lesions show large, empty-appearing spaces, thin endothelial linings, and little to no red blood cells because they contain lymph, not blood. Big picture comparison is think of these as parallel developmental errors. Hemangioma is abnormal blood vessel proliferation, and lymphangioma is abnormal lymphatic vessel dilation. Both are developmental, benign, most common in childhood, and usually managed conservatively. If you remember nothing else from this slide, remember this. Red plus blood-filled plus skin, think hemangioma, and soft, cystic, lymph-filled mass, think lymphangioma. These are pattern recognition lesions, exactly the kind pathology loves. Up to this point, we've focused on structural and mechanical aspects of the vascular system: pressure, fluid, movement, lymphatic drainage, and developmental abnormalities. Now we're shifting into a different but closely related category: inflammatory and degenerative diseases of the blood vessel. This section is less about where the fluid goes and more about what happens to the vessel wall itself over time. What does inflammatory mean here? Inflammatory vascular diseases involve damage to the endothelium, activation of immune cells, increased permeability, and altered blood flow. These changes can weaken vessel walls, promote thrombosis, and disrupt normal tissue perfusion. Inflammation is often chronic, meaning the damage accumulates gradually rather than suddenly. And what does degenerative mean? Degenerative processes reflect wear and tear, aging, chronic injury, and metabolic stress. Rather than a single triggering event, degeneration develops over time and leads to vessel stiffening, loss of elasticity, narrowing of lumens, and reduced blood flow to tissues. Why this matters clinically and histologically? From a pathology perspective, these diseases are important because they are common, they are often progressive, and they underlie major clinical conditions like ischemia, infarction, and organ dysfunction. Histologically, you'll start to see thickened vessel walls, inflammatory infiltrates, lipid deposition, in fibrosis and structural distortion. Think of it this way. Earlier slides asked, how does fluid move? This section asks, what happens when vessels themselves become damaged over time? That distinction is key as we move forward. This slide introduces a term you'll hear a lot in both pathology and clinical medicine, arteriosclerosis. At its core, arteriosclerosis means hardening of the arteries. But that phrase is a bit misleading because arteriosclerosis is not one single disease. It's a broad umbrella term that includes 3 distinct pathological processes, each affecting different vessels and different layers of the vessel wall. So big picture first, arteriosclerosis refers to loss of elasticity, thickening of vessel walls, reduced ability of arteries to respond to changes in blood flow. All 3 processes ultimately impair perfusion, but they do so in different ways and in different vessels. So arteriosclerosis affects small arteries in arterioles. Pathologically, this involves thickening of the intima and media, progressive narrowing of the lumen. This form is especially important in chronic hypertension, diabetes, and kidney disease. From a histology standpoint, you often see thickened vessel walls, reduced lumen size, and ischemic changes in downstream tissues. This is a major contributor to end organ damage, especially in the kidneys and brain. The second is medial sclerosis. Medial sclerosis, also called Monckeberg medial sclerosis, is different. Here the key feature is calcification of the media of large arteries. Important distinction, the lumen is usually not significantly narrowed. Blood flow may be relatively preserved. Clinically, this condition often occurs in older adults, is discovered incidentally on imaging, and contributes to vessel rigidity rather than obstruction. So this is more about loss of compliance, not plaque blockage. And then we have atherosclerosis, the most famous one. Atherosclerosis is the form most people think of when they hear arteriosclerosis. Key features, plaque formation in the intima. It affects large and medium-sized arteries. Lipid-rich plaques composed of cholesterol, inflammatory cells, and fibrous tissue. Over time, these plaques narrow the lumen, weaken the vessel wall, and may rupture, triggering thrombosis. This is what underlies coronary artery disease, strokes, and peripheral vascular disease. The image on the right shows the progression. So plaque formation, plaque growth with endothelial damage, plaque rupture, and then thrombus formation limiting blood flow. Why this matters in pathology? Arteriosclerosis is extremely common, often progressive, and a major contributor to morbidity and mortality. Histologically, you'll be expected to recognize which vessel layer is involved, distinguish plaque from calcification, and understand how vessel changes relate to tissue injury. Think of arteriosclerosis like this. Arteriosclerosis is small vessels, wall thickening. Medial sclerosis is calcified media, stiff vessels, and atherosclerosis is intimal plaques and luminal obstruction. Same umbrella term, very different pathology. Now we're going to zoom in on atherosclerosis specifically, because this is the form of arteriosclerosis you'll see most often in both histologic specimens and clinical correlations. Atherosclerosis is often described as a lifestyle disease, meaning it's strongly associated with modified behaviors such as unhealthy diet, obesity, smoking, and lack of physical activity. That said, lifestyle is only part of the story. We'll talk about risk factors in a moment. What defines atherosclerosis? Well, pathologically, atherosclerosis is characterized by fatty deposits within the arterial wall. These deposits are called atheroma. They form in the intima of large and medium-sized arteries. Early in the disease process, these lesions are known as fatty streaks. Important concept is that fatty streaks do not significantly obstruct blood flow. They are reversible, but they are the precursors to more advanced plaque formation. As plaques mature, they become larger, more fibrotic, and more likely to narrow the lumen, as well as more prone to rupture. Risk factors for atherosclerosis are commonly divided into 2 groups. So major risk factors, These have a strong, well-established association with disease and include hyperlipidemia, smoking, hypertension, diabetes, age, and genetics. And then there are minor risk factors. These may contribute but usually play a smaller role on their own, such as stress, sedentary lifestyle, dietary patterns. One of the most important concepts on this slide is the multiplier effect. This means risk factors don't just add up, they interact. For example, smoking plus high cholesterol plus hypertension is far more dangerous than any one factor alone. This is why patients with multiple risk factors often develop earlier disease, more severe plaque burden, and a higher risk of plaque rupture and thrombosis. The diagram on the right shows a normal artery with smooth blood flow progression to plaque accumulation, narrowing of the arterial lumen, and disturbing blood flow. From a histology perspective, this correlates within lipid cores, foam cells, fibrous caps, and chronic inflammation of the vessel wall. These changes explain why atherosclerosis is both a structural disease and an inflammatory process. As a key takeaway, atherosclerosis is a disease of the intima, driven by lipid accumulation and inflammation, influenced heavily by multiple interacting risk factors. Understanding this process helps explain ischemia, infarction, and why prevention and early intervention matter so much. Now we're going to break down the major risk factors for atherosclerosis. These are called major because each one has a strong, well-documented causal relationship with disease development, not just an association. What's important to remember is that every one of these risk factors damages the vascular endothelium in some way, making plaque formation more likely. So hyperlipidemia, which refers to elevated lipid levels in the blood, particularly LDL cholesterol. LDL is a problem because it can penetrate the endothelial lining and become oxidized and be taken up by macrophages, forming foam cells. These foam cells are the foundation of fatty streaks, the earliest visible lesion of atherosclerosis. Diet plays a major role here. Diets high in saturated fats and trans fats increase LDL levels, which accelerates plaque formation. From a pathology standpoint, hyperlipidemia fuels the lipid core of an atherosclerotic plaque. Hypertension. Hypertension increases atherosclerosis risk by about 50%, which is significant. Why? Because high pressure physically damages the endothelial lining, increases vascular permeability, and promotes smooth muscle cell migration into the intima. Both systolic pressure and diastolic pressure matter because they represent chronic mechanical stress on arterial walls. Think of hypertension as making the artery wall more vulnerable to every other risk factor. Cigarette smoking. Smoking is one of the most powerful modifiable risk factors. Smoking causes direct endothelial injury, promotes inflammation, increases platelet aggregation, and reduces oxygen delivery. 1 pack per day doubles the risk of death from coronary artery disease. From a histologic perspective, smoking accelerates plaque growth, plaque instability, and the risk of rupture. Next up is diabetes. Diabetes significantly accelerates atherosclerosis. Chronically elevated blood glucose damages endothelial cells, alters lipid metabolism, increases oxidative stress, and promotes inflammation. This is why patients with diabetes often develop more severe disease at younger ages and more diffuse vascular involvement. The good news is tight blood glucose control reduces risk even though it doesn't eliminate it entirely. Obesity contributes through multiple overlapping mechanisms, so increased lipid availability, insulin resistance, chronic low-grade inflammation, and increased blood pressure. People with obesity or high caloric intake, especially diets rich in carbohydrates, saturated fats, and processed foods, have a higher incidence of atherosclerosis. Importantly, obesity often clusters with other risk factors, multiplying overall risk. Hyperhomocystemia. This one is less intuitive, but still important. Hyperhomocystemia means elevated levels of homocysteine, an amino acid in the blood. High homocysteine levels damage endothelial cells, promote thrombosis, and increase oxidative stress. Even though it's less common, it's considered a major risk factor because of its strong vascular effects. So big picture takeaway, each of these risk factors damages the endothelium, promotes lipid accumulation, fuels inflammation, or increases thrombosis risk. And when multiple risk factors are present, they don't just add up, they compound, dramatically increasing disease severity and clinical consequences. Before we go any further with atherosclerosis, we need to pause for a moment and talk about lipids, because how lipids move through the blood is central to plaque formation. Why lipids need help in the blood is because free lipids, especially fatty acids and cholesterol, are not water soluble. Blood plasma is mostly water, so lipids can't just float around on their own. To move through the bloodstream, lipids must attach to plasma proteins, forming a transport particle called a lipoprotein. Think of lipoproteins as shipping containers. Protein on the outside, lipid cargo on the inside. The amount of protein versus lipid determines how dense and how dangerous that particle is. So high-density lipoproteins, or HDL. HDL particles are about half protein and half lipid. Because they contain a higher proportion of protein, more phospholipid and cholesterol they are. Smaller, more stable, and better at removing cholesterol from tissues and vessel walls. This is why HDL is often referred to as the good cholesterol. From a disease standpoint, higher HDL levels are associated with a decreased risk of vascular disease. HDL helps transport cholesterol away from the arteries and back to the liver for processing. HDL is protective, not because cholesterol is gone, but because it's being handled correctly. Then we have low-density lipoproteins, or LDL. LDL particles are only about 22% protein, meaning they contain much more lipid, especially cholesterol. This makes LDL larger, less stable, and more likely to deposit cholesterol into vessel walls. LDL is referred to as bad cholesterol because it readily enters damaged endothelium, becomes oxidized, and is taken up by macrophages. That process leads to foam cell formation, fatty streaks, and ultimately plaque development. LDL isn't inherently evil, but in excess and in damaged vessels, it becomes pathogenic. Very low density lipoproteins, or VLDL. VLDL particles are only about 10% protein. Most of their lipid content is triglycerides, not cholesterol. VLDL is primarily involved in transporting triglycerides from the liver to tissues. However, as triglycerides are removed, VLDL particles are remodeled into LDL. So VLDL is an upstream contributor to LDL levels. This is why elevated triglycerides often travel alongside elevated LDL in metabolic disease. The key idea here is balance and handling, not just presence. Lipids must travel as lipoproteins. The protein to lipid ratio matters. HDL tends to remove cholesterol from vessels, LDL tends to deposit cholesterol into vessels, and VLDL contributes to triglyceride transport and LDL formation. In atherosclerosis, the problem isn't cholesterol alone, it's how much, how it's transported, and what condition the vessel wall is in. Now we've covered the major risk factors for atherosclerosis. Let's talk about what are considered minor risk factors. That label can be misleading. Minor does not mean unimportant. These factors typically can't be changed, or they modify risk rather than directly cause disease. But when combined with major risk factors, they significantly increase overall cardiovascular risk. So age, atherosclerosis actually begins at birth and progresses silently over time. Fatty streaks can be found in children and even in adolescents. However, clinical disease becomes much more likely with age. Risk increases dramatically, about fivefold between ages 40 and 60. This reflects cumulative exposure to lipids, to vascular injury, and to inflammation over time. Atherosclerosis is not sudden, it's a lifetime process. Gender plays a role largely due to hormonal influences. So premenopausal women experience fewer atherosclerotic events than men of the same age. Estrogen is thought to have protective vascular effects. After menopause, that protective effect is lost, and the prevalence of atherosclerosis in women rises sharply. eventually approaching or matching that of men. This is why cardiovascular disease becomes a leading cause of morbidity in older women. Family history. Family history reflects genetic influence. Inherited factors can affect lipid metabolism, blood pressure regulation, glucose handling, and inflammatory responses. A positive family history doesn't guarantee disease, but it lowers the threshold at which other risk factors become dangerous. This is why early screening matters in patients with strong family histories. And then activity level. Physical activity is one of the most powerful modifiable protective factors. Regular exercise can lower LDL and triglycerides and increase HDL. It reduces blood pressure and improves insulin sensitivity and also helps regulate body weight. All of these effects reduce endothelial injury, slow plaque progression, and decrease overall atherosclerotic burden. Sedentary lifestyle doesn't cause plaques directly, but it removes protective mechanisms. And then lastly, psychological factors. So chronic emotional stress and depression are increasingly recognized contributors. They are associated with increased sympathetic nervous system activity, elevated cortisol, higher blood pressure, and unhealthy coping behaviors such as poor diet, smoking, and inactivity. Over time, these factors increase vascular inflammation, endothelial dysfunction, and plaque progression. The takeaway here is that vascular disease is not purely mechanical, it's systemic. Minor risk factors shape who is more vulnerable and when disease becomes clinically significant. They don't usually act alone, but when combined with major risk factors, they create a multiplier effect that accelerates atherosclerosis. Understanding these helps explain why two patients with similar cholesterol levels may have very different outcomes and why prevention must be individualized. This slide walks us through the stepwise development of atherosclerosis, and the key idea here is that it is a chronic, progressive inflammatory process, not just passive fat buildup. Let's move through it in order. Endothelial injury is the starting point. Atherosclerosis begins with subtle, non-lethal injury to endothelial cells. This injury does not kill the cells outright. Instead, it causes endothelial dysfunction, which means the endothelium becomes more permeable, loses its protective antithrombotic properties, and begins expressing adhesion molecules. Some common contributors include hyperlipidemia, hypertension, smoking, diabetes, and chronic inflammation. Think of this as the artery's inner lining becoming leaky and irritated, not destroyed. Okay? Second is lipid accumulation at the damaged site. So once the endothelium is compromised, LDL cholesterol enters the intima. LDL becomes oxidized. Monocytes migrate into the vessel wall. These monocytes differentiate into macrophages, which ingest lipid and become foam cells. This stage corresponds to fatty streaks, which can be seen early in life and are still potentially reversible. Next up is the smooth muscle cell migration and inflammation. So next, smooth muscle cells migrate from the media into the intima. At the same time, macrophages and lymphocytes accumulate. Inflammatory mediators are released. Smooth muscle cells begin producing the extracellular matrix. The lesion is no longer just lipid, it is now cellular and inflammatory. And then D is progressive plaque expansion. With time, there is continued accumulation of lipid, increased numbers of foam cells, and ongoing inflammation, as well as expansion of the plaque into the lumen. Blood flows becomes increasingly restricted, and the vessel wall becomes less flexible. This is when plaques begin to have clinical significance, even if the patient is still asymptomatic. Then lastly, fibrosis and formation of a stable atheroma. So finally, chronic inflammation stimulates collagen deposition, fibrosis, and formation of a fibrous cap. This produces a hard, stable atheroma. While stable sounds reassuring, these plaques narrow the vessel lumen, impair blood flow, and can still become dangerous if they progress or rupture. Big picture takeaway is that atherosclerosis starts with endothelial dysfunction, progresses through lipid accumulation and inflammation, and ends with fibrotic plaque formation. It is best understood as a slow burn inflammatory disease of the arterial wall, influenced by both lifestyle and non-modifiable risk factors. Now that we understand how atherosclerosis develops, this slide focuses on what happens when plaques progress and destabilize. These complications are why atherosclerosis is such a major cause of morbidity and mortality. We have progressive luminal narrowing, also called stenosis. As plaques enlarge over time, they narrow the arterial lumen, a process called stenosis. Reduced blood flow leads to ischemia, which is inadequate oxygen delivery to tissues, or infarction, which is tissue death due to prolonged ischemia. Early on, ischemia may be intermittent and exertional. As stenosis worsens, symptoms can occur even at rest. One of the most dangerous complications occurs when a plaque ruptures or ulcerates. This exposes thrombogenic material, triggering platelet adhesion, coagulation, and thrombus formation. A classic example is myocardial infarction, where rupture of a coronary plaque leads to rapid thrombus formation and acute vessel occlusion. Important concept is that it is often plaque instability, not plaque size, that predicts acute events. A thrombus forming on a plaque does not always stay in place. It can break off, travel downstream, and lodge in a smaller vessel. This can cause sudden ischemia in tissues distant from the original plaque, such as brain, as in a stroke, kidney, or distal limbs. And then we have aneurysm formation. So chronic plaque formation also weakens the structural integrity of the vessel wall. Loss of elasticity and medial damage can cause the vessel to balloon outward under pressure, form an aneurysm. If an aneurysm ruptures, it can result in life-threatening hemorrhage, particularly in the aorta. Clinically, atherosclerosis most commonly presents as coronary artery disease, or CAD, which is a heart attack, or cerebrovascular disease, which is an ischemic stroke, an aortic aneurysm, or peripheral vascular disease, which is chronic limb ischemia, non-healing ulcers, and possible amputation. These outcomes reflect where the plaques form, not differences in the disease process itself. So the big picture takeaway is atherosclerosis is often silent for years, becomes dangerous through stenosis, thrombosis, embolization, and vessel wall weakening. It links microscopic pathology to major clinical events. Understanding these complications helps explain why risk factor management is so critical long before symptoms appear. Slide shows a gross comparison between normal arterial endothelium and advanced atherosclerosis, and it's a really important visual for understanding how dramatic the vessel surface changes. So normal endothelium, on the left, you see normal arterial endothelium. Key characteristics are smooth, glistening, and pale pink. The smooth surface is critical because it allows laminar blood flow, resists platelet adhesion, and helps maintain normal vascular function. In a healthy vessel, blood should move through with minimal resistance and minimal turbulence. Atherosclerotic vessel on the right is advanced with clearly visible atheromas. These plaques are not just fat. They are a complex mixture of lipid, cholesterol and fatty material, fibrous connective tissue, macrophages, many of them foam cells, and lymphocytes. This reflects the chronic inflammatory nature of the disease. Early lesions, such as fatty streaks, are relatively subtle and flat. Over time, these evolve into raised plaques, firm fibrotic lesions, sometimes calcified areas. This progression explains why atherosclerosis often develops silently over decades before symptoms appear. The end result is an endothelial surface that is rough, stiff, irregular, and described as having a caked appearance. This roughened surface disrupts blood flow, increases turbulence, promotes platelet adhesion and thrombosis, and reduces vessel elasticity. From a histotechnology perspective, this gross appearance correlates directly with what we see microscopically, which is thickened intima, inflammatory infiltrates, and a fibrous cap formation. So big picture takeaway is that this slide reinforces an important concept. Atherosclerosis is not just a narrowing problem, it is a surface and structural disease of the vessel wall. Once the endothelium loses its smooth, protective character, the risk of thrombosis, embolization, ischemic injury increases significantly. Okay, this slide is very intentional. Up to this point, we've talked about endothelial injury, lipid accumulation, inflammation, plaque formation, and vessel narrowing, and some pretty serious downstream consequences. So before we move forward, this is your moment to pause and reset. Atherosclerosis is not a single-step process. It's gradual, cumulative, and influenced by multiple interacting factors. Trying to rush through it without stepping back often leads to confusion, especially when we start layering clinical correlations on top of pathology. The image on the left represents a stop or timeout moment, and the image on the right literally says take a breather. And yes, I mean that both figuratively and literatively. If you're watching this lecture, pause the video, take a breath, stretch if you need to, review the last few slides. It's a good time to mentally organize what starts the disease, what makes it worse, and what it ultimately leads to. So a big picture takeaway reminder before we take a break is atherosclerosis is a chronic inflammatory disease. It's driven by endothelial dysfunction. It's worsened by modifiable and non-modifiable risk factors and is expressed structurally as plaque formation. If you can keep that framework in your head, everything that follows will make more sense.